going to have any more slides, and we would like to see the audience and be able to discuss together. And switch off that light, this one here, please. Okay. Are there any questions from the audience?
Or comments.
Or comments, suggestions, any ideas? Yes, please, you get a microphone.
There's a microphone down there in the floor. So. Yeah.
Donald.
Yeah.
It's more intimate, I hope. I'm Donald Bruce, and I've been doing ethics of nanomedicine since about 2003 or 4. And I was part of the nanotechnology engagement group on the ethics panel rather than the patients panel. And I'm just checking back at my own files of that. And that report, which was referred to, was 2009, those recommendations. And I'm just thinking, I'm rather shocked to realize how little has happened in terms of engaging patients since Alistair Kent sort of formulated those recommendations, whereas the technology is shot ahead. So I'm sort of, it's just a reflection of surprise from my own point of view to realize that actually quite a long time ago that that very important piece of work was done. But just to say, another area that concerns me, a lot of what you were talking about was there was some clinical trials, is in the area of diagnostics, where nanotechnology has a very particular ethical implication with a large social impact, is in the scale at which people will have advanced information about their health status, where thus far a few families with a genetic disease would be very familiar with all the problems and risks. But if you weren't part of one of those families, this would be something other, something over there. Whereas with lab on a chip and all these other technologies, sometime in the not too distant future, advanced knowledge of a health situation, of a risk of this, that, or the other cancer, or whatever it might be, would be normal. And I don't think our healthcare system is prepared for that. In a sense, we are all, in that sense, patients needing support. So just to flag up that there's another area, apart from the treatment, in terms of just how do we handle diagnostics, in which we are all becoming ill persons. So I just wondered if anyone wants to reflect on that.
Who wants to?
I think it is even a bit more complex because diagnostics and therapy are going to merge. We see that already in the area of hypothermic treatments and so on. So you're perfectly right. This is, I simply use the term complexity to describe this. It's a much broader thing. It is on the one hand side, the application, the indication, what it is being used for. But it all starts from the very beginning what nanotechnology is and understanding what's actually the difference between a small-sized particle and a nanoparticle. Now, this is about physics, and I think this is where many of the also ethical challenges originate from, because if a particle becomes so small, it behaves like an atom, and atomic forces are becoming more relevant than the chemical structure itself, or it's a combination of both. And the first thing we have learned about nanoparticles is that they are able to travel through the body into places where a normal particle never goes. And then one of the early experiences was that some of these particles then can give rise to inflammation. And here you have two things together. You have a harmful event and you have the lack of control. Now, lots of research has been done to manage these two things, but as we also could hear here, we are far away from having resolved all of them. So the problem is these uncertainties relate to assessing what are the potential issues we are facing, and we can't even quantify them. While on the other side, on the benefit side, we have seen already a lot of positive events. But as we know from other new technologies, it can take a long time until this comes out. So what can we do in order to ensure that we are not just blindly following like we did with nuclear energy, which we all praised at the very beginning and then suddenly realized there are lots of pitfalls with it which no one at the time foreseen. So this is basically the issue, and mingling therapy and diagnosis then becomes an additional one, yeah.
As a researcher and then as a regulator. Just ironic.
Okay, are there other comments to that topic? I mean, one thing is this, how much has happened in that aspect. I mean, technology has made big progress in the last 10, 15 years, but in our debate, we practically are still in the same stage where we have been years ago.
I mean, just in general about patient involvement in research, I think there's been a tremendous progress over the past years. I mean, Alistair Kent has certainly been one of the pioneers in that space. But if I see what has happened alone in, I mean, HIV is one of the examples where people usually don't talk about, but there are highly educated patient advocates in almost any kind of research that's happening there. While in cancer, we are a bit behind, but I would say since I started cancer patient advocacy in 2003 or 2002, so much has happened, and we have so many engaged patient advocates which are engaging on all the different fields. But I think one thing that we need to address is, and I think that's particular when you mention these risks like Detlef was mentioning, what's the risk of not taking risks? And that's probably where you have different perspectives from different patient advocates, because I was just at a different conference here in Basel this morning where a patient advocate who's leading a pan-European network on metastatic melanoma was presenting, who lost her husband about my age about 3 years ago. And she presented about the risk of not taking risks, because the melanoma community says, don't overprotect us. We want to decide ourselves what kind of risks we take. And if nanomedicine actually delivers the promise, or wants to deliver the promise that we're all betting on, we need to take risks. And I think we patients are very well aware, but we need to be part of that process, because probably we can see that regulators and sometimes researchers are probably more risk averse than some patient populations are, which say our patients are dying anyway. Look at melanoma. Hardly any of the advocates is alive after 1 year.
I have maybe another addition also, because I was taking, not today, but yesterday, a conference in Brussels on what is called adaptive pathways, which is also a new way of licensing medicines. And there was one statement who will stay, and it is in line with what you're saying, Jan, that, so to say, the less data, whatever there is, the less knowledge we need to take decisions on, and that is also this fact in adaptive pathways, the more involvement is needed of, so to say, the end user. And that is in itself not so easy, because how could you take informed decision on limited knowledge? So there is another ethics discussion.
Do you want to? Sorry, yes, please.
Sorry, yeah, you're absolutely right. We should not overprotect patients. You're absolutely right. But on the other side, yesterday we had a nice panel discussion in the Montreal Hall. It was regulated from all over the world, and we had the regulators from most states. And everybody was saying, you know, we have to define toxicology. We have to really address all these issues. And there was one from the ethical committee from Nigeria, and he said, you know, if we have somebody suffering from a severe disease, and there's no other solution, and there's a new technique, and the patient is confident that this might be helpful for him, we let him do this. This never will happen in Germany or in Europe. So we have regulations on the one side, protecting new innovation, and on the other side, we have patient wishes, yeah, for new solutions. But this is this is a discrepancy, and I think at the moment, especially here in Europe, we have a lot of tasks to overcome this problem.
I think this is a very, very interesting topic, and we could spend, I think, a whole conference on it. Firstly, I would really to confirm that I fully concur, Jan, with what you said. And when I mentioned risk, I didn't do that with the intention to say we shouldn't do things. But it is my firm belief I can only take a risk if I know about it. Otherwise, it's just ignorance. And unfortunately, this is a bit the situation where many people are. And that's why I highlighted the outcome of the roundtable, which I really, firstly, I agree, it's a shame that this was the last time such a big project was done with patients. I think we urgently need something similar. But if at the very end the conclusion is we are all in favor of it, but we don't know what it is, then I'm getting nervous. So for me, it is important that we don't push any recognized issues under the carpet, but rather put them to light and together develop strategies to get around them. So this is, I think, the key thing, and I have read a position paper of an association which stated that there are no problems and no issues with nanotechnology compared to other medical technologies. At this stage, this is certainly overstated, to be very, very simple. Now, with regard to the comment you made with regard to Nigeria, we have the proper processes in place. I think we just have to recognize there is a big difference between a public body like a regulator releases something for the broader market, so you can buy it somewhere and everybody believes this is safe, or a doctor or a patient make a decision to use a certain treatment which hasn't undergone all these checks and balances, and you are, as a doctor, perfectly free to do that. No. You are. The only point is you take the responsibility for it, and it is under your control. If a patient wants access to something, even if it is not available in your country, there are processes in place to import it from a country where it is available and to use it. So these processes are there, and I'm happy to explain this more in detail if you wish, but the regulations are in place. So the problem still remains that finding the right balance between control on the one hand side and leaving it all to individual decision making is a very tricky one, and I think that in any case will require a broad public dispute.
Yes, please. I have a couple of questions. Can you use the microphone as well, because I think it's getting recorded?
Is it on? So, as I said, I'm a doctoral student in medical ethics, and I have been working for the last 3 years on ethical issues of first-in-human clinical trials of nanomedicine. So probably I'll start with you, because you made this statement that patients not always think about safety, but they are really looking for innovation and interventions that could save their lives. In nanomedicine now, there is a push to also go beyond cancer, where the situation is that you might have other treatment modalities which are probably not perfect, but they are still treatment options. So at one end, you have this, and on the other hand, there is uncertainty and unknowns and even ignorance in a lot of these therapies. Would you still hold the same statement about all the disease spectrums, or it's only for diseases where absolutely it's a question of life and death? That's the first question, and it could be answered by anybody. And second question is also with the patient advocacy groups, and as I'm doing the literature search and reviews, one of the conflict of interest that gets discussed is if the patient advocacy groups are being funded directly or indirectly by pharmaceutical industries. And then in that case, how do we make sure that the views that are expressed by the patient advocacy groups are without the conflict and really in the best interest of the patients?
Okay, who wants to start?
I mean, I can talk about both things. The first thing is about other diseases. Certainly, cancer is not the only area. You have other life-threatening diseases. Of course, let's say risk aversity or willing to take risks is different in diseases where you have little options. So whether it's rare diseases, whether it's certain kinds of malignant diseases, non-malignant diseases, it depends on the severity and the number of options that are there. Certainly, it's more difficult to run trials in diseases where you have a lot of treatment options and where the comfort level is relatively high. So from that perspective, I wouldn't reduce it to cancer, and I would certainly say from the 6,000 rare diseases, we find a couple of thousand where there's hardly any therapy there. So from that perspective, I think that might answer your question. The other issue is about funding. Of course, that's a very popular topic, and we could spend another conference on this topic. The challenge is that there's hardly any funding for patient organizations out there, especially on the European level. I mean, look at the budget of the European Commission, which they're spending on patient organization, and look at European foundations that are funding patient organizations. So it's always a very easy argument that industry is putting our head off our body because they're just funding our organizations. This is not true. We're very independent, but of course we need funding to run our organizations. And I must say, I'm leading, well, I can say that, I'm leading a pan-European project, half funded by the EU and half funded by industry. And I must say, the influence on content of public funding is much higher than the influence of industry on what we do. And I think we're self-confident enough to decide what we as patients want and what our priorities are. I would say the constraints, compliance, legal requirements on industry are so high today that they're rather constraining what we could do than letting anyone influence us. So I'm not concerned about this area, I must say.
If I may just very briefly, at least in my country and in my practice, I am facing very strong distrust of the general population towards the science and towards the classical medicine and towards the doctors even. So this distrust is very, very strong. And this brings also the patients in the situations that they do believe in anything that is offered to them. And many times, even the very educated person, like the professor in mathematics or in physics or in biochemistry or whatever, he is unable to distinguish between the alternative medicine that is mere stupidity and the real progress, progressive medicine and nanomedicine or something that is really worth to, I think, to pursue or so. So this is the relatively new situation. I think this is different that it was 10 years or 15 years ago because of internet and because of many other reasons, also sociological reasons and so on. But we have to face it also. So we have somehow to re-educate the general population and all the patients at the prerequisite of better involvement and a better decision-making capacities and a better collaboration, that we really should somehow make the space for the intelligent dialogue between all these parties.
As someone who was involved in such things from an industry perspective, also would like to add that yes, there is a concern that these contributions would influence. But as the traditional deontological ethics initiated by Kant says, it's about the motives in the first place and not about what you do. And the motives of industry and industry would be badly advised if they would think differently. And I'm not talking about each and every individual case, I can't, but in general, is the least influencing patient organizations. It is really because there's a clear recognition that there is benefit in having patients involved in such programs. And this only works if patients have an opportunity to participate. And they can only participate if they have funding. And I think that was the reason why at the Nanomed Roundtable, there was also a clear request to the European funding organizations to provide contributions, funding, in order to allow patients actually to participate. And I can only subscribe to that. But we have indeed, and this does not only refer to patient organizations, a significant part of the research work done in public institutions, not only in Europe but also in the US, is funded by industry. If you would take that money away, the research would in a moment completely collapse. I'm actually on the board of a research foundation and the requests for funding have increased by the hundredfold over 2 years of time, simply because there are so many constraints with funding also on that side. And there's also an argument that if a company is involved in such a foundation, that will be influencing research. I think it is about transparency. So we should not talk so much about whether there is a conflict of interest. There is nothing without a conflict of interest. I think that is pretty clear. No researcher has no conflict of interest because the researcher is interested in promoting career, in following his research interest, and that very often has more impact on the outcome than has funding. It is about transparency. It's about making visible who is behind the money, who has potentially an influence on that person, and then it's on us on the other side of the table to judge this and to build trust or not.
Okay, I think we have already eaten at least 5 minutes of your coffee break. Trying to summarize what we have heard is a challenge because we had so many important ideas, topics, suggestions that none of them should be forgotten, and I think we have a tape here, so we will be able to summarize that. But what I draw as a conclusion for myself now is that in fact we have a couple of steps to do. Number one is really to increase and improve the information to the public about the technology opportunities, about the chances, but also the risks in general. As a step number two, I think we need to define the different situations that we have in the different type of diseases concerning their adapted benefit risk judgments that they require, because every patient population is in a somewhat different situation, and for that already, for this step number two, we need already the patients. I mean, we also need the patients in step one to adapt the information on new technology to lay language and to a way that patients and the public at large can understand the potential and the risks of that technology. So patients in helping to translate that information that goes to the public, patients involved in the discussion of the benefit risk assessments in the different situations. Step number three, I think, is the need to enable more opportunities. Today we had 90 minutes and we are a very small group here, and there needs to be many more opportunities in a much larger scale to hold these multi-stakeholder discussions, to develop strategies that are adapted to the different patient needs, to the different technology options that we have for the different diseases, because we cannot do a one-size-fits-all. It needs much more sophistication in the discussion. And number four, or step number four for me, would be to create and help to create the regulatory, ethical, and societal environment to develop nanotechnology in a responsive and responsible way, because I think that we have heard several times now also that doing what we have to do in an intelligent way with respect to the patient, but accepting that the patient is the end user, has the right to tell us what we need, and to do what we do with responsibility and responsiveness. So thank you very much for having joined the Alien session. I hope you could take home some, further ideas, and of course, if you have a possibility to work on one of these steps that I was just mentioning, then we have achieved something. Yes, please.
I have a card game on display, which is part of a NanoAthero project, where I am trying to do some of this engagement for the benefit of potential patients who will be part of clinical trials in this, and also the wider public. It's one model amongst many other ones that could be used, but if anyone is interested in having a look at it, please do. And thank you very much for a really good session.
Thank you.
That's been very good.
And thank you very much to all the speakers and panelists and for having joined us here. And I hope
for the audience.
And for the audience. And I think it will be the first of several discussions that we are going to have together. Thank you very much.